Assalamu alaikum wa rahmatullahi wa barakatuh. You're listening to ReviveFM Podcast. This is a family medicine podcast where we review pertinent articles, reform our understanding of medical education, and aim to revolutionize the practice of family medicine with our voices. Welcome to ReviveFM. This is your host, الجوهرة السعدون. With each episode, we will have 3 respected guests joining us. 1 family medicine physician and 2 family medicine residents. الله يحييكم ضيوفنا الكرام. الضيوف اليوم قريبين القلب كثير وحقيقة سعيدة جدا باستضافتكم بالاستديو معانا. دكتورة بيان، دكتورة نورة ودكتور صالح. تعرفون بنفسكم؟ نبدأ معاكي دكتورة بيان.
حياك الله الدكتورة الجوهرة. أنا دكتورة بيان AlAjaji, Associate Consultant Family Medicine in Johns Hopkins Aramco Healthcare. It is a great pleasure to be here with you today. I've been listening to ReviveFM in the past episode. It's really interesting. I'm really grateful to be here with you today. Thank you so much.
الله يحييكي دكتورة. إحنا اللي نتشرف بحضورك حقيقة. دكتور صالح تعرفنا بنفسك؟
السلام عليكم، يعطيك العافية الجوهرة. I'm صالح AlShawi, Family Medicine Resident at Johns Hopkins Aramco Healthcare. I'm very pleased to be with this nice group recording this nice episode.
حياك الله دكتور صالح. وعندنا دكتورة نورة، تعرفينا بنفسك؟
السلام عليكم، يعطيك العافية الجوهرة. أنا نورة الحميد، Family Medicine Resident at مدينة الملك فهد الطبية تابعة التجمع الصحي الثاني في الرياض.
حياك الله نورة. وجدير بالذكر إن اليوم أول ضيفة لنا من الرياض as a resident. حيا الله الرياض وأهلها. Our episode today has a very special flavor. It covers a bit of a different scope of family medicine. And I'm sure by the end Dr. Bayan has a special announcement to make. صح دكتورة؟
إن شاء الله بإذن الله.
كلنا متحمسين. So our episode today is on urgent care. To begin with, Dr. Bayan, اسمحي لي أسألك. Why urgent care for family medicine faculty and residents? And what's the scope of urgent care?
Thank you دكتورة الجوهرة على هذا السؤال الجميل. Urgent care medicine has a unique knowledge base, skills, and requires a broad experience. Although urgent care medicine has a distinctive practice, it also shares most common with family medicine and emergency medicine. But I have to add that it differs from the regular family medicine scope, that its main concern is with acute symptoms and management.
Sounds great, and we're very excited to start, especially that many residents are going to cover urgent care very soon, especially myself. And I believe it will be case-based discussion, right?
Exactly. Dr. Saleh and Dr. Norah have prepared most common complaints that is presented to the urgent care setting. We will approach them and manage them accordingly.
حلو. The floor is yours, دكتورة بيان, دكتور صالح, دكتورة نورة.
طيب نبدأ first case مع الدكتورة نورة. Start.
Okay, so this case, I chose this complaint because it's very common. So 3 to 5% of patients presenting to the UCC complain of headache. So I thought we would approach that. We have a 37-year-old female presenting to the UCC complaining of headache. How would you like to approach her?
تفضل دكتور صالح.
Yes, I would like to start with detailed history. So at the beginning, we would like to start with the demographic data, and the age of the patient is important. And then we can assess the pain itself, the character of the headache. So pattern and onset of the pain is important to ask. Prior history of the headache, if it is the first time to present with this headache or he has a previous episode. The patient activity, so the impact of the headache on his life is also important. If there is a history of head trauma, this is also need to be addressed in the history. Carbon monoxide exposure, the intensity of the headache. So if patient came with, if he's mentioned that it is the most severe headache in my life, so this is needed to be addressed.
Hello.
Character also of the pain, the location of the pain, and aggravating and relieving factors.
Excellent. So you took a very detailed history. What is your next step, Dr. Nora? Are you familiar with the CHI algorithm? مجلس الضمان الصحي أصدر لنا بعض الالجوريثمز اللي It really helps with unifying our approach to the patients in the family or the primary care settings. Are you familiar with it, Dr. Norah?
Yes, so there is the algorithm regarding a patient with headache, and it usually starts with history, like Dr. Saleh mentioned. After that, you move on to the physical examination, which includes fever. If the patient has high blood pressure, you should also check for signs of meningitis. If the patient is above 50, then you should palpate the temporals. Also, you should do a full neurological assessment to make sure there is no neurological deficit. And also, you should do a fundoscopy to make sure that there is no papilledema. After that, you should exclude the red flags.
Speaking of papilledema, I was going to ask you about the red flags of headache. Are you going to mention them? Or Dr. Saleh will?
Yes.
Okay.
So talking about the red flags, there is a mnemonic called SNNOOP10.
Mm-hmm.
So each letter will stand for one of the red flags. So S stands for systemic symptoms, including fever and constitutional symptoms.
Mm-hmm.
The N, the first N, is neoplasmic history. So if the patient has a history of neoplasm, you need to make sure that it is not metastasized to the brain. The other N is neurological deficit and impaired level of consciousness. The first O is onset, is it sudden or abrupt? And the other O is older age. So any patient older than 50 years of age is a red flag. The first P, since there is 10 Ps, the first P is pattern, if it is changed or it is a recent onset of new headache.
Hello.
What else, Dr. Norah, comes to your mind?
Okay, I'll continue the 9 Ps. So positional headache. Is the headache precipitated by sneezing, coughing, or exercise? Is there signs of papilledema or not? Is the headache progressive or atypical presentation? Is there pregnancy, history of trauma, post-traumatic, painful eye, pathology of the immune system, or the patient uses painkillers, so painkiller overuse?
So let's go back to our case. You have taken history, you have performed comprehensive physical examination. Let's go back to our case, Dr. Norah. What happens now?
Okay, so regarding our patient, upon history taking and physical assessment, she says that it lasts for a few days, this headache, if she did not treated it. It's usually unilateral, pounding, associated with nausea and photophobia. Sometimes it's preceded by visual disturbances that completely subside. She's vitally stable and her examination is unremarkable.
Excellent, excellent. So at this point, let's touch base. What are the differential diagnoses that comes to your mind, Dr. Norah?
Okay, so first thing, the most common headaches to present are primary headaches, around 90%. The most common of them is tension headache, which is usually bilateral, band-like, subsides after analgesia, lasts for a few minutes. Then we have migraine, which I think our patient has. Usually it's unilateral, pounding, disabling, if not treated would last a few days, associated with aura that is completely subsiding after the headache. And then the least common is cluster headaches, usually unilateral, associated with lacrimation.
Perfect. So you spoke of primary headaches. Dr. Saleh, talk about secondary headaches. What is there?
So there is a lot of secondary headache to be mentioned. There is the common one, which is the sinusitis, which present with secondary headache. And there is less common headaches, secondary headaches, like drug overuse, which might induce the headache. And there is some a bit serious, which is trigeminal neuralgia or temporal arteritis and meningitis.
Perfect. Thank you so much. So would you, at this point of your case, would you order any type of imaging for this patient? Would you refer her to the EMS?
Okay, so regarding our patient, since we're considering migraines, CTs is not indicated, especially that she does not have any red flags, and there is no roles for X-ray.
So would you send the patient home? Would you send her to the EMS? Would you like to actually refer the patient acutely or urgently to any of the specialities?
Okay, so our patient, again, since she has a primary headache, which is migraine, I would send her home with regular follow-ups on cimetroptan and pain management as needed. Also, I would tell her to avoid her triggers and to keep a sleep diary. But I would refer her to the EMS if, let's say, she has fever or symptomatic symptoms or painful eye, then yes, I might consider referring her to the EMS.
Perfect, Dr. Norah. So let's recap on our case. A headache, as we mentioned before, is one of the most common cases or presentations that is seen in daily life clinic. It is so first, when a patient is coming to you with a complaint of headache, you will approach the patient by taking detailed history, comprehensive physical examination, ruling out red flags, and managing according to your diagnosis.
صحيح، يعني تكاد لا تخلى أي عيادة من أحد يشكي من صداع يا مريض يا faculty، صح؟
صحيح.
So keeping the CHI algorithm you mentioned is excellent, especially for us as residents. It will help us to be organized in our approach. And since we're discussing pain, how about we discuss all the questions about pain? وبعدها ناخذ كلنا ibuprofen مع بعض. I believe it would be back pain next.
Yeah, actually a case is prepared by Dr. Saleh اللي هي low back pain. Would you like to proceed, Dr.?
Yes, sure. So we can talk about how frequent back pain in primary care and urgent care setting and visits. في global researches تقول إن prevalence of back pain related complaints account more than 50% of the visits in the primary care and urgent care visits. So my case is a 43-year-old male who came to the urgent care clinic with history of back pain since 3 days.
Okay.
What do you want to do next?
Okay, so I think we should start in a very detailed history regarding the pain, following the Socrates mnemonic, so site, onset, characteristic, is it radiating, is there any associating symptoms, timing, exacerbating factors, and severity. And then we might do a physical examination.
Excellent, Dr. Norah. Dr. Saleh, would you like to add anything else?
Sure, you should ask the patient if this pain is a new pain or chronic. If the patient presents to you with another attack of chronic pain, it will be different than new pain. Also, you can ask the patient if there is any event participated to this back pain or not. You can ask the patient also if there is a medication response, if he tried any analgesia and that helped with him. And you can ask him about constitutional symptoms.
Excellent. Dr. Norah, moving from the history to the physical examination, what are you going to keep in mind?
Okay, so I should do a full back exam. I should also do a straight leg rise examination.
Excellent. So we've concluded the history taking, we've done a comprehensive physical examination. What are your differential diagnoses, Dr. Saleh?
Sure. You can differentiate your diagnosis regarding the back pain into three main categories, which is mechanical, non-mechanical, and visceral diseases. So if you want to have a differential diagnosis of mechanical, you could think about the musculoskeletal system, which is the normal muscular strain, degenerative diseases like spondylosis and spondylolithiasis, osteoarthritis, and also you need to keep in your mind herniated disc, spinal stenosis, and fractures.
Okay, regarding the non-mechanical causes, if the patient is elderly and they have histories of cancer, then you should keep neoplasms in the back of your head. So you think of multiple myelomas, metastatic carcinoma, lymphomas and leukemias, spinal cord tumors, or retroperitoneal tumors. If he's presenting with signs of infection like fever, then you have to keep osteomyelitis, perispinous abscesses, and epidural abscesses. And you should also keep inflammatory arthritis such as ankylosing spondylitis.
Perfect. Dr. Saleh, you mentioned visceral. Elaborate more on that.
So not all back pain causes are related to the spinal area. So some of them are related to visceral organs. So pelvic organs could present with low back pain, prostatitis, chronic pelvic inflammatory diseases. Also renal diseases like nephrolithiasis or pyelonephritis could present with low back pain. Aortic aneurysm also can present with low back pain. Pancreatitis, cholecystitis, penetrating ulcer also can present with low back pain.
Absolutely, Dr. Saleh. I can't agree more. Actually, I had a patient with recurrent UTI who presented only with a symptom of low back pain. So every time she would come to the clinic, Dr. Bayan, I have low back pain. We would run a urinalysis. Nitrate would be positive. We would treat her as UTI, and the lower back pain symptom would completely resolve.
Okay. It's good to keep it in mind since it could be a sole symptom to have.
Absolutely. Dr. Saleh, let's get back to our case.
Okay. So my case, he mentioned that he has this low back pain since 3 days back. And he scaled it 6 out of 10. He tried painkillers, which was not helping. And he relayed this pain after lifting an oven at home a week back. So a week back, he lifted this heavy object. And 3 days back, he started to have this pain. There is no relation to daytime, and there is no constitutional symptoms.
What about the physical examination, Dr. Saleh?
So upon physical exam, he have limited range of motion due to tenderness and negative straight leg rising test. And there is no signs of scoliosis.
طيب اسمح لي هنا أبغى أسأل عن ال red flags for back pain.
Okay, Johara, I will answer that. Regarding red flags, you should look for bowel or bladder sphincter dysfunction, saddle anesthesia, intolerable pain at rest or at night, constitutional symptoms like fever and weight loss, and history of cancer.
حلو.
Again, you should keep in your mind of the red flags if the patient is known to have severe osteoporosis or known to have a long-standing use of steroids. This is also a red flag. If the patient is IV drug abuser or known to have any immunodeficiency or having any infection symptoms, this is also a red flag. If the neurological symptoms are getting worse or he has a history of spinal surgeries, this is also a red flag. And at the end, if the patient is older than 50 years of age, this is also a red flag.
واضح.
So what about our patient? Does he have any red flags, and what is your management?
So since my patient is 43, he has no red flags at all. And about the management, I would like to treat him conservatively. I will just reassure the patient. I will ask him to stay active and avoid bed resting and resume his daily activities. I will tell him avoid twisting or bending, and I will start him trial of non-steroidal anti-inflammatory drugs with paracetamol.
Perfect, Dr. Saleh. I totally agree with you on this management, but let me propose a question. In the urgent care setting, in the emergency department, also in the primary care setting, patient would not be agreeing with your management plan. They would ask, Dr. Saleh, please, can I have an MRI? How would you manage this question?
Sure. طبعا, this we see a lot in the practice, patient insisting for MRI. Again, like what we did in our first case, which is the headache, مجلس الضمان الصحي مسوي a good algorithm, which is MRI indication for low back pain, and divide it in 3 regard the chronicity of the pain. So less than 6 weeks, from 6 to 12 weeks, and more than 12 weeks. And this algorithm reserved the MRI for only red flag indicated patient.
Okay, so what about a patient who is presented with this pain, Dr. Saleh, for less than 6 weeks? How would you approach him?
So less than 6 weeks with no red flags, you treat him conservative.
Mm-hmm. What about a patient who has this pain more than 6 weeks?
So from 6 to 12 weeks with no red flags, again, you should assess if he tried the conservative management or not. If he did not, you will treat him conservatively. If he tried the conservative management, you will check that if he completed the treatment or not. If he did not complete it, then you will start him again on the conservative management, and you will reassess again after 2 weeks.
Okay. What about if the patient's having the pain for more than 3 months, 3 to 6 months, let's say?
So any patient more than 12 weeks, خلاص, this is a red flag. You will need to do an MRI urgently, regardless the trial of analgesia or conservative management.
Perfect. Thank you, Dr. Saleh. So, recapping the case of lower back pain, this is a common case seen every day. We would approach the patient by taking detailed history, comprehensive physical examination. Also, we would have to rule out the red flags Dr. Norah and Dr. Saleh talked about. Then we would treat according to the case. If the patient needs any investigation, any further imaging, then we would order it and we would follow up in the primary care setting.
حلو. So since we discussed this thoroughly, I believe it's time for the third case. Am I right?
Absolutely, دكتورة. الدكتورة نورة حضرت لنا case which is very special.
Okay, the case I prepared, I chose it because I used to have a cat and I used to get cat scratches and bites. A lot of pet owners, a lot of people love animals and they usually sustain animal bites.
صح يا دكتورة نورة. Actually, I'm a cat owner myself, so I totally can relate. نحبهم، نعطف عليهم، ودنا نرحمهم، بس أحياناً يكون في خطورة علينا. أتفق تماماً. تفضلي.
I agree with that, Dictora. So the case is a 29-year-old male presenting after sustaining a dog bite. How would you approach this patient?
So first, I would ensure if the patient is hemodynamically stable or not, and there is no life-threatening condition.
Perfect. So your patient is hemodynamically stable. Dr. Norah, how would you assess him?
Okay, so you start with wound assessment and history taking together. You have to look at the wound itself, location of the bite, type of the animal that bit him, a time since the bite, and history of immunization regarding the patient himself and the animal. Also, you have to assess for injuries to adjacent structures and skin. You have to make sure there is no deep puncture wounds on the hand, in the head, in the neck. And you have to evaluate for foreign body and fractures. Also, you have to do a neurovascular assessment distal to the wound, and you make sure there is no signs of infection.
Excellent. On the signs of infection, Dr. Saleh, what are the risk factors for infection?
Sure. طبعا first you would like to check if the patient is immunosuppressed or not, and this most commonly diabetic patient. Second, if the bite involving the hand or foot, this is a risk factor. The third risk factor, if the bite is in the extremity with underlying venous or lymphatic compromise.
Adding to Dr. Saleh, bite near a prosthetic joint or vascular graft, crush injury or puncture wound. Cats, unfortunately, are associated with higher risk. Also, delayed presentation, which is more than 12 hours on the extremities and more than 24 hours on the face.
Perfect. So this leads me to the important question is how to differentiate between superficial and deep infection, Dictora.
Okay, so superficial infection we think of cellulitis, so راح يكون في redness, tenderness, erythema, swelling. Also, it might have a superficial abscess that might be tender.
Perfect. طيب, Dr. Saleh, that leads us to the deep infection. What do we mean by that?
So to know if this infection is deep, you would say that patient is having a pain is persistent or getting worse after several days من ال initial injury, or if the patient is having this pain with the passive movement. If there is crepitus, also this indicates a deep infections, and if there is joint swelling. Also, if the patient having this systemic illness manifestation like fever or hemodynamically instability, this might indicate deep infection.
صحيح, Dr. Saleh, I couldn't agree more. I would also like to emphasize on the importance to always keep in mind that diabetic patients, immunosuppressed patients, should get a very detailed history and examination. They always raise the red flag for risk of infection. They might present later in the course with a risk of serious infection because at the initial presentation, they might have limited pain or on clinical examination. So back to our case, Dr. Norah. Could you give us a summary?
Okay, so upon assessment of our patient, he is vitally stable, medically free, not sure regarding his immunization status, but the dog is fully vaccinated. The bite is on his arm. It was 4 hours ago. There is no active bleeding, and the rest of his examination is unremarkable.
Perfect. So, going back to our patient, how would you manage the animal bite at first?
So first, we start with the wound assessment, which we briefly mentioned. You should give local anesthesia. You have to clean the wound, make sure there is no foreign body. If you're suspecting fractures, then you might do X-ray. And you should, if you think there is a deep infection, then you should take wound cultures to guide the antibiotic therapy. And if you're suspecting sepsis, you might take blood cultures, but at that point you have to refer him to the emergency.
Okay, perfect, Dr. Nora. Dr. Saleh, this takes me to a very important question. Should we close the wound?
Sure. So you need to close your wound if it was in the cosmetically important areas like the face. You need to close it. Otherwise, there is a lot of conditions that you need to avoid closure of the wound. Like if the wound was more than 12 hours and if it was 24 hours in the face, you don't want to close it. If the wound was clinically infected, you avoid to close this wound. If the patient was immunocompromised, you will avoid to close this wound. And if it was located in the hand or in the foot.
Perfect دكتور صالح, شكرا. طيب, نجي على سؤال مرة مهم اللي هو antibiotic prophylaxis. دكتورة نورة, could you elaborate more on that?
Sure. So if you decide to close the wound, then you should give antibiotic. If it's deep puncture wounds or moderate crush injuries, if the wound is on the hands or genitalia, if it's close to the bone or joint, and if the patient is immunocompromised, usually we treat with 3 to 5 days of augmentin.
حلو. طيب, allow me to ask you here regarding the recommendations on tetanus prophylaxis.
Okay, so tetanus prophylaxis, since the animal bite breaks the skin, you should ask the patient regarding his immunization status. If he's received more than 3 doses in the last 5 years, then you only give him the tetanus toxoid. If he did not receive the 3 doses or he's not sure, then you give the tetanus toxoid and the tetanus immunoglobulin.
حلو. طيب, what about the rabies post-exposure prophylaxis?
So there is a rabies post-exposure prophylaxis, which is limited to high-risk wild animals like the bats, foxes, or high-risk domestic animals like dogs and cats. So you have 2 options. You can give the rabies immunoglobulin unless the patient was previously vaccinated. You can inject those immunoglobulin most into the wound site and you inject it intramuscularly. The other option is to give rabies vaccine on the days 0, 3, 7, and 14 on 4 doses. And if the patient was immunocompromised, you would give a 5th vaccine dose on day 28.
حلو, واضح.
Okay, so Dr. Nora, would you order any investigations, any imaging for this patient at this moment?
Okay, so regarding our patient, he does not require any imaging, any investigations, or any antibiotics. This patient was discharged after receiving a tetanus toxoid and tetanus immunoglobulin since he wasn't sure. Also, we did not give him antibiotic or rabies prophylaxis.
Perfect. Thank you so much, Dr. Nora, for this interesting case. To recap, everyone, animal bites are commonly seen on daily clinics or in the urgent care setting. We have to assess the patient's immunization status. The assessment of the wound should be done carefully, and we should manage appropriately to the patient's case.
I'm personally enjoying this episode a lot, but unfortunately we have come to the last case, I believe. صح دكتورة بيان?
Absolutely, دكتورة الجوهرة. We are all enjoying this episode, but we have come to the last case prepared by Dr. Saleh. Would you like to start?
Yes, sure. So you are in the urgent care clinic and you have this lady, 55-year-old, who came to the urgent care clinic with history of right leg swelling since 3 days back, lower limb edema. So what's your differential diagnosis?
Okay, so top of my differentials would be deep venous thrombosis, DVT, muscular strain, venous insufficiency, cellulitis, also less commonly popliteal cell structure, drug-induced, such as calcium channel blockers, heart failure, and renal failure.
Absolutely, Dr. Nora. Now, coming to this case, what would you like to ask more about in the history of this patient?
Sure. So I will have a detailed history and comprehensive physical exam. In history, I would like to cover if there is any history of immobilization or prolonged hospitalization, a recent history of surgery or trauma within the last 3 months, obesity, previous venothromboembolism, malignancy or constitutional symptoms suggestive of malignancy within the last 6 months.
Also, I would like to ask about the use of oral contraception pills or hormonal replacement therapy, strokes, hemiplegia or immobility, family history of venous thrombosis, embolism, heart failure, and inflammatory bowel disease.
Perfect, Dr. Nora. Dr. Saleh, could you tell me what are you going to look for in physical examination?
Sure. So you will see in the exam, you will assess the both legs. If there is any unilateral or bilateral swelling, you would like to measure the calf muscles and the thigh diameter. Also, you would check for warmth, tenderness, erythema. Also, you would like to look for any tenderness along with the course of the involved major veins. If there is any signs of malignancy, and you also would like to check the chest and the abdomen by examining them.
Excellent. I couldn't agree more. So let's go back to our case, Dr. Saleh. What do you have in your case?
So my case, she is known to have hypertension, diabetes, and rheumatoid arthritis. 3 days back, she noticed that her right shoe is not fit anymore. With digging more in the history, she had a total knee replacement 5 weeks back, which needed a week of hospitalization. Within the physical exam, her BMI is 35. She's vitally stable, and her right calf muscles are 3 centimeters greater in circumference than the left one.
Okay, so how will we actually manage this patient in the UCC? Will you order ultrasound right away? Will you order a D-dimer? Will you discharge the patient safely to home? How are you going to manage her?
So there is a score which will guide us and help us, which we will do a D-dimer or ultrasound called a Wells score and modified Wells score, which will measure the probability of deep vein thrombosis. And it has a lot of points you can score it and calculate it. So if the patient having any active cancer or treatment ongoing within the past 6 months, it will score 1 point. If the patient is having paralysis, it will score 1 point. If there is a recent bedridden for more than 3 days or major surgery within the 4 weeks, it will calculate 1 point. And also, if there is an entire leg swollen, it will score one point.
What else, Dr. Nora, comes to your mind?
Adding to that, calf swelling by more than 3 centimeters when compared to the asymptomatic leg, pitting edema in the symptomatic leg, collateral superficial veins. So you add 1 for each. If there is an alternative diagnosis that is more likely to be the actual diagnosis than DVT, then you subtract 2 points.
Okay, so that is very clear. But let me ask you, Dr. Saleh, low probability, moderate probability, high probability, what does that mean?
So if you want to interpret these findings, if you have any 3 points or more than this, it is high probability to have deep vein thrombosis. If the patient have 1 or 2 points only, it is a moderate probability. And if he has 0 or less, it will be low probability.
So what about our patient?
So any low probability or moderate probability, you could safely just do the D-dimer without an ultrasound. And our patient was only having 2 points. So you will do only a D-dimer.
Excellent. That sounds good. So you ordered the D-dimer as an urgent or a stat order. And what was the result?
So the result of my patient was 800, which is positive, and the cutoff is 500.
How will you manage this patient?
So any positive D-dimer, you will send him to EMS for whole leg ultrasound to rule out deep vein thrombosis.
Excellent, excellent. Thank you, Dr. Saleh, for this interesting case. Let me share with you the story that happened to me, actually. On my first shift in Johns Hopkins, I had actually one of my first patients presented to me in the urgent care setting. رجال كبير بالعمر in his 70s. دكتورة راح تحويلي على العظام، ارجعي حوليني يا دكتورة على العظام. فقلت له ما يخالف يا عم، أبشر، بس علمني وش المشكلة. فهي replied إنه والله ما في شيء، بس أمس رحت للمسجد ورجلي توجعني. Upon taking further history, examining the patient, he had just a mild tenderness in the right lower limb, a very mild tenderness. There is no edema. يعني upon digging in his history and his file, he had actually several D-dimers in the past 6 months. They were all negative. He had 3 ultrasound of the lower limb venous system, which were negative. He was diagnosed by orthopedics to have a leg radiculopathy. But I calculated the modified Wells score. I was not assured to discharge the patient safely home. So I ordered the D-dimer, and upon the result was actually positive. Patient was referred to the EMS. He underwent ultrasound urgently, and we discovered that he had a massive DVT in his right lower limb. So alhamdulillah, we caught him. I urge all of you to just be a safe doctor. Trust your instinct. This is really actually يعني a life-saving procedure. So yeah, that's it.
I believe this is a lesson to never underestimate any patient's complaint.
Absolutely, دكتورة الجوهرة. Absolutely.
Yes.
This was indeed a very comprehensive overview with important points to keep in mind during our work in urgent care clinic, inshallah. But Dr. Bayan, would you like to give us like a take-home message?
Absolutely, دكتورة الجوهرة. يعني I would like all family medicine faculty to keep in mind that there are many different cases that you might face in the urgent care setting, and not only the ones we spoke of today. We discussed the most common cases, but focusing on the approach in the urgent care clinic and how to differentiate between your approach in your normal primary care clinic and your approach in the urgent care clinic or in the urgent care setting is a key to provide optimum patient care. Of course, I encourage you always, do not hesitate to ask for help. And stay calm and be alert, everyone.
Indeed. I think it's just the right time to make the big announcement. Don't you think, Dr. Bayan?
Absolutely, دكتورة الجوهرة.
Go ahead.
So I am privileged and honored to invite you all to the 2nd National Urgent Care Conference. As the chairperson of the organizing committee, I am delighted to meet all of you this year in person. It is a prominent collaboration between emergency medicine and family medicine, which will allow us all to meet landmark speakers of both specialities. I hope to see you all. Stay calm and be alert, and see you next weekend from the 9th to the 11th of February.
Inshallah.
Inshallah, in الخبر. And we hope to see you.
It's a pleasure to be invited by the chairperson of the organizing committee. So I'm sure Dr. Saleh, Nora, and I will be attending, inshallah.
inshallah يا دكتورة الجوهرة. حياكم الله جميعا ونتشرف فيكم.
Again, thank you, Dr. Bayan, Dr. Saleh, and Dr. Nora.
Thank you.
شكرا لك دكتورة الجوهرة.
It was a pleasure to have you in our podcast.
شكرا لكم.
If you're interested in reviewing the topics of discussion of this podcast In the link below, you will find the core scientific content that was created by our dear guest residents. If you would like to join us and become a guest at ReviveFM Podcast, you can fill out the application form found in the description box below. This podcast is brought to you by the Saudi Society of Family and Community Medicine, as well as Family Medicine Future Group. Continue to follow our podcast on social media through Saudi Society for Family and Community Medicine and FMF Twitter accounts linked below. Currently, we upload regularly on both Apple Podcast and YouTube. This has been your host, الجوهرة السعدون. Thank you for tuning in. We hope to hear you next on ReviveFM Podcast. As always, sky is home.